Welcome to all the people who are joining us in webinar 234 since the Andean Health Organization Hipólito Unanue Agreement started the webinar cycle in May 2020. It is 4 years of continuous interlearning since we started this cycle of webinars in May 2020. Also, since February of this year, we started the cycle of hybrid webinars with the British Embassy, so thank you very much. Today, it is a pleasure to present the webinar named British Vision on Primary Healthcare. In the Strategic Plan for Health Integration 2023-2030 of Horas CONU, we always argue that to ensure the full realization of the right to health with social and environmental justice, it is key to work intensively on strengthening the health systems, always emphasizing primary health care. In 1971, with the creation of the Hipólito Unanue Agreement, the governments of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela joined together with a sense of solidarity and regional integration to make health a bridge for peace and work for well-being. Thus, today, we have an important journey of unity and the constant work of sharing between the ministries of health of the 6 Andean countries to materialize the right to health. In the midst of technological globalization, the COVID-19 pandemic restated the relevance of the health sector for life with well-being. That is why today this is a priority to keep health at the forefront of the policies and social awareness to unite for the common good, to advance in a society that cares for life. Health is the bridge towards integration and peace. Reflections such as these and the summary of our actions can be found in the Noti Salud Andinas Bulletin, the monthly edition, which we invite you to read, and it's also available at the Horas CONU webpage and in the Andean Integration Knowledge Showcase. We all invite you to leave your name, organization, and country in the comments box of the Facebook Live chat or YouTube Live. In that space, you can leave your questions or send them via the email at webinarhorasconu@gmail.com. To access the certificate of attendance, as usual, in any of the Facebook Live or YouTube Live chats, you will find a fixed link where you will have to fill out a short survey and leave your data as your email. Please verify that your email is correctly written for the certificate to be sent there, which will be sent in the next few days to your email address. At this webinar, we will follow the following dynamic. We will begin with the institutional greetings, then we will have the keynote speeches and comments, and then we will have a dialogue based on the questions from the audience, from the participants. We invite you all to write down your questions and comments. To kick off this important day, I will now give the floor to Dr. María del Carmen Calle Dávila, who is the Executive Secretary of Horas CONU. Dr. Calle. Dr. Ciro Abel Mestas Valero, Vice Minister of Health Services and Insurance Ministry of Health of Peru. Mr. Rodrigo Acevedo, Manager of the British Embassy in Peru, to all the participants in the room, the British Embassy team, representatives of the Ministry of Health, the Comptroller's Office, Horas CONU, distinguished speakers, and to all of the participants as well who have joined us in this call. The Andean Health Organization Hipólito Unanue Agreement, Horas CONU, was established by decision of the Ministers of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela in December 1971. In the strategic plan for integration in health 2023-2030, the number 6 outcome is called strengthening of the health systems and primary health care. I would like to remind you that all the documents of Horas CONU have been signed by resolutions by the ministers of health of all of these 6 countries. So when we speak about the strategic plan, we are referring to some degree of consensus reached by the 6 countries, and this is why we consider it is important to dwell on primary health care. Since May 2020, we've been holding weekly webinars to promote the ongoing learning. I consider that this is mutual learning. We learn, but you learn as well. And the idea is that this is ongoing and constant. All of the webinars that we have held are published on our website. Those 234 that we have had before, and we have them both in English and Spanish. We also have public from outside of America. I would like to welcome you all to this webinar number 234, British Vision on Primary Healthcare. These are the special webinars with the British Embassy. We started having webinars which are special because we consider that there should be an exchange with the British Embassy and with the British experts. We consider this exchange to be of most importance. Now, regarding the relevance of addressing primary health care, the Declaration of Alma Ata in 1978, as well as various publications, like, for instance, the Renewing Primary Healthcare in the Americas of 2007, the Declaration of Astana of 2018, and the report implementing the primary healthcare approach in 2024 highlight. And I'm sure that all of you know about this, but it is always good to remember that health is a fundamental human right. Primary health care is the first level of contact of people with the health system. The role of human resources trained in primary health care, the empowerment of people and their participation in decision making are essential. A model of care that responds to people's needs as soon as possible and throughout the process, that grows from health promotion, disease prevention, treatment, rehabilitation, and palliative care is essential as well. To have adequate, accessible, scientifically sound, and socially acceptable health technologies and access to quality medicine is essential as well. It is also basic to have health systems that ensure universal access to quality and comprehensive services. The fundamental role of the government in the steering role and governance of primary health care, ensuring its adequate financing, effective regulation, and decentralization is also fundamental. We know about the role that we've played throughout this whole time. We met some months ago at the Committee of Economy, of Health and Economy, with all of the experts to see how to work around financing of primary health care. The research and innovation to generate evidence that will guide decision making is important, and we have agreements with universities from other countries to keep on implementing primary health care, always prioritizing the training of human resources. We also have an agreement with ESalud. We've signed this just a couple of months ago, and we kept on working under a certain consensus with them. The relevance of the leadership and political will to implement prevention. The priority is to overcome the fragmentation of health systems and the inequalities and that exist in the health system. Horas CONU works upon two pillars. One of them is that anyone who lives under our jurisdiction of these 6 countries needs to have access to health at the highest level possible. And secondly, working to decrease the inequalities on health. Among many other aspects, primary health care is a fundamental approach to guarantee universal access to health, and it is the foundation for the capacity building of the essential functions in health. This is why today we are setting out to share the British vision on primary health care and to promote the analysis of the challenges to strengthen this in the Andean region. We reiterate our the gratefulness to the British Embassy. I would like to extend a warm welcome to our speakers, experts from the UK, Dr. Meena Gupta, Clinical Director of Modality Partnership, and Dr. Vincent Sai, CEO of Modality Partnership, and also to our guests for their comments from the Ministry of Health and Social Protection of Colombia, Catalina. Catalina is an advisor to the Ministry of Social Protection of Colombia, and Dr. Ciro, Mesta's Vice Minister of Peru. And of course, we welcome the comments of everyone who's here. Together we are stronger. Together we go farther. So welcome, welcome to all of you. Thank you very much, Dr. Mari Carmen, for your kind words. Now we will hand the mic to Dr. Rodrigo Acevedo from the British Embassy. Thank you very much, Berta and Doctor, for your kind words. I would like to convey the greetings from the ambassador. He was not, unfortunately, he's not here, but he would like to give some words. First, say hi to everyone, Vice Minister, Doctor, representatives of the Salud, the Comptroller's Office, and other institutions, and of course, Vincent and Mina and Catalina. Thank you very much for being here and joining us. As the doctor mentioned, we started this webinar cycle 5 months ago. It's been a very positive experience that worked very well for Horas CONU on the embassy because we've had the chance to reach many more countries, many more people with topics that I think are worth discussing as a priority. We will discuss primary healthcare. We've had 2 prior webinars with different issues, including mental health, digital health, among others. The message from the embassy is our intention to promote these discussions, putting health in the forefront of our interests, which is one of our priorities at the international level. Well, thank you very much for your time, for being here. We hope that your presentations will be very useful, and we will be here for anything that you need after this webinar or any other relevant topic on health and any other topics that you would like to discuss. Thank you. Thank you very much, Rodrigo. Now we would like to hand the mic to Dr. Ciro Mesta, Vice Minister of Health Insurance from the Ministry. Good morning, everyone. Dr. María del Carmen Calle, Dr. Rodrigo Acevedo, on behalf of Gavin Cook, the ambassador, to the representatives of the Ministry of Health and the representatives from different countries, and greetings for the representatives of the Comptroller's Office. I would like to convey the greetings from the Minister Cesar Vázquez, who's always paying attention to everyone that deals with strengthening the first care level. Now, talking about primary health care, I think that it is better to do this in English. I think that we have to speak about cuidados primarios de salud in Spanish. Sometimes this is not something that we've cared for. And I think that it is better to call it like this in Spanish. Well, that's just a note. We have read about it in all of our publications. We have to clearly understand what are some elements of public health. The policies have been outlined a long time ago, but we have to put them in practice. And this is something that has to do with our own territories, to look for people where they live, not only look after the people, but their families, their surroundings, the community at large, and also the environment. I'm sure that if we do this, we will be able to reach one health and a better country. We have thought that we need to bear in mind other determining factors, social factors, and also at the local level, we have to consider education and health services. The conditions of better human development and definitely the environment. We in Peru, which is one of the Andean countries that shares the Amazon and the Andes with some of our neighbors. All of this, I say, because we have to reinforce our first care level, strengthen the first health care level by creating local competencies to manage health and manage universal care. This is why we need finance, and everything will work if there's honesty and good intentions, because the right to health is immediate. We cannot put this off, and we can have a better local care for our people. This is about the right to health, and this is why we need the most valuable thing, which is human resources, people, to look after people, so that they will stay healthy. If we do this, costs will always go down. For decades at our country, we've been thinking about benefits first, which is also important, but this is not the main thing. Then we have technology and then we have human resources. But the rationale is all the way around. First, we have to strengthen human resources. Then we can use technology to assist, and whenever possible, infrastructure. This is why we need to have better conditions, and better conditions with knowledge, because this is what lies in the heads of people who look after people. And financing is also essential. It needs to be better administered from the first healthcare level. Historically, this is how we did it. First, by working on the most complex issues. If we are to treat cancer, we are dealing with public health failures. Now, there are many expensive drugs which sometimes we cannot afford. But then we have vaccines, we have diagnosis, If we don't start with this, then dealing with a serious disease is therefore more difficult. We need to serve the majority of the population. So, to our guests, I would like to thank you for being interested in Peru, and we are certain that we will share a lot of knowledge at this webinar, because now it is not about learning from each other, but sharing knowledge. Health is a common responsibility, a global responsibility. After seeing the pandemic effects and this living in this world of migration, we need to work together. And I'm sure that by working together with the ambassador, David Cook, I think that with all of us, we will be in a better position to work with the British government to reach universal healthcare for everyone, to work together, to collaborate, and to reach one health from before birth, equitable health, to give more to those who need the most, to deal with inequalities, and health that is participatory, always listening to our patients, listening to their opinions. If we keep on doing this and we keep on working like this, I'm sure that we will have a better world. Thank you very much to all of you. Thank you very much, Dr. Ciro. And after these important greetings, I would like to introduce myself. I'm Berta Restrepo. I'm a sociologist and a coordinator of climate change and inequalities in the Andean Health Organization. And today I will gladly be in charge of moderating this webinar. We would like to welcome Dr. Meena Gupta. I would like to thank you all, Meena Gupta. Dr. Meena Gupta has been a director of Modality Partnerships since 2012 and has held leadership positions with responsibility for community, specialty clinics, and primary care delivery. She has also led the redesign of services, especially for seniors. This includes community volunteer services, a large dementia case finding project, and a community physical and mental health clinic. In addition, she established strong clinical governance procedures within nursing homes, leading teams of nurses, pharmacists, and physicians to raise standards of care. We are also joined by Dr. Vincent Tsai. Dr. Tsai has over 25 years of experience in primary health care. He's chief executive and partner of the Modality Partnership, an award-winning association of public health service physicians that operates primary health care and community services throughout the United Kingdom. Dr. Tsai has played a pivotal role in expanding Modality's national presence since joining in 2015. Under his leadership, the partnership has grown, currently providing services to over 7 million citizens across 50 sites in 9 regions of the UK. Modality Partnership's exceptional work has gained national and international recognition. Its innovative approaches to primary care have been rigorously evaluated by prestigious international organizations. In addition, the partnership has been honored with major national awards. Go ahead, Dr. Gupta, Dr. Tsai.
Thank you very much for the warm welcome and a special good morning to the ministers and to all distinguished guests. It is our privilege and an honor to be here on this special edition of a very meaningful forum of sharing. Dr. Gupta and myself have prepared a little video to begin our session. So if you could bear with me, I will share that video first, and then we will proceed with our talk for this session.
In England, the National Health Service, or NHS, provides essential services to millions of people across the country. At the heart of this system lies general practice. General practice, often referred to as GP, is where the journey of healthcare begins for many. Let's delve into the basics of the general practice in the NHS. Firstly, GPs are primary care physicians who play a crucial role in the healthcare ecosystem. They are usually the first point of contact for patients with non-emergency medical issues.
As GPs, we provide comprehensive medical care, treating common illnesses and also focusing on long-term conditions like hypertension and diabetes. We also provide preventative healthcare, offering vaccinations and screenings to prevent illnesses before they occur.
One of the key strengths of general practice is its patient-centered approach. GPs build long-term relationships with their patients, understanding their medical history, preferences, and needs. When necessary, GPs coordinate care with specialists and other healthcare professionals, ensuring seamless transitions and comprehensive care for their patients. Over the years, general practice has evolved and now includes a diverse and dynamic group of professionals, each playing a vital role in delivering comprehensive healthcare.
Nursing in general practice involves a wide range of responsibilities, from wound care and vaccinations to chronic disease management. We provide holistic care and support patients on their healthcare journey.
As a pharmacist working in general practice, I ensure patients understand their medications and how to take them safely. Collaborating closely with GPs, we optimise medications management and improve health outcomes.
In general practice, allied health professionals like myself provide specialised expertise to help patients. We look at things like physiotherapy, mental health support, nutritional counselling, working collaboratively with the primary care team to enhance patients' needs.
Together, these professionals form a cohesive primary care team, collaborating to deliver patient-centered care that addresses the physical, mental, and social aspects of health. Accessibility is another hallmark of general practice. With GP practices located in communities across England and extended hours of services, patients can access care when they need it. Technology plays an increasingly vital role in modern general practice, enabling GPs to access patient records securely, communicate with colleagues, and deliver online appointments.
My GP practice provides different options to suit my needs. Whether that's booking a face-to-face, online, or telephone appointment, I really appreciate the flexibility and convenience.
In summary, general practice is the cornerstone of the NHS, providing holistic, patient-centred and accessible healthcare to individuals and families throughout England.
I will switch now to our presentation slides. May I just check if the screen is showing correctly for everyone?
Yeah,
Thank
I
you.
can see correctly.
So thank you again for the opportunity to share our thoughts today. Let me begin by grounding the audience on modality a little bit more, because by having this base knowledge, you will be able to appreciate better some of the thoughts and comments that we'll be sharing throughout this presentation. So we became a partnership 15 years ago. So this is our 15th anniversary. And we came together with 2 practices in a very poor part of Birmingham in the West Midlands in England. We have grown over time working with like-minded partners to future-proof primary care, because we believe it is a key anchor and the bedrock of the National Health Service. We believe that it is a key part to many health systems, as has been mentioned so far this morning. You will see here on our slide that we have grown considerably, cutting across many regions, and being able to work at scale has allowed us to look at the population level. And I'm proud to say we've actually surpassed the 7 million that was mentioned at the beginning. My team has just reported to me this past week that we have now grown to have a reach to more than 8.5 million citizens in England. And our work cuts across from primary care to community services. Although we started as primary care physicians or general practice, we have learned over the years that there's many connecting capabilities that is very important to help build towards a sustainable health economy. So we started working in the community setting from an outpatient standpoint. We have branched to do research. It is very important that we're part of using data in a safe way to advance medical technologies. We have done projects to look at helping patients or citizens with rare diseases. That is also very important. And we've also done work where we are leading the clinical trial for an earlier detection of ovarian cancer. There is a lot that primary care can bring to the table. We believe in lifestyles management. This is a key to the future. We're involved in that. We're also involved in various data, automation, and of course, everyone is talking about artificial intelligence. We are also involved in shaping and testing that out for the benefit of the populations we serve. We also are involved in making sure our estates are in good shape and order, especially with sustainability, to ensure we have a sustainable service. And last but not least, we strongly believe in training and development, the future generation, and a third of my fellow partners are GP trainers in the UK. So we train the future general practitioners in England. We are providing different expert advisory support to different governments and health ministries. And we have done different work in recent times around the world. For example, our joint venture in Vietnam, where we are trying to introduce more integrated care to the system. We have a partnership emerging in Brazil, where we're looking to share our experience through leadership training, development, and accreditation. So we are excited to have this broad range of experience, which we are or will be delighted to share with any colleagues post this session to explore opportunities to make a difference for you in your countries. I wanted to base everyone on how the National Health Service works and is funded. As many of you are aware, we have a new government, and I have no doubt that there will be many plans put in place to continue to improve our services in the Kingdom of United Kingdom. But the fundamental flow and funding of the health service is one that is triggered from the top, where we are a single payer with funding from the taxpayers' funds, from Treasury, and that is passed on to the Department of Health and Social Care, which then governs the big funding that then devolves to NHS England, and they then are the statutory commissioners who then provide the funding across the different regions, flowing to different providers. General practice, it only represents 10% of the total spend of the health system in the UK, but we see nearly 90% of all encounters because we are the first point of contact. We are clearly a highly effective and value for money service that is key to the sustainability of the system. By the way, I neglect to mention from the beginning that no health system is perfect, and neither it is in the UK. There are many, many challenges, and I think it's important to point that out. But together, not just in England or the UK, internationally, like forums like this, we can share together to improve for the common cause of helping people. But you can see there's significant funds involved here in healthcare, but this is generally the flow from the government publicly funded system out to statutory commissioners to providers. Over the past few years, the National Health Service has been organizing itself into integrated care systems. It is very challenging to manage the healthcare of the whole country. So logically, it needs to be broken into the right geographical basis and a common framework to make it sustainable. So, and some of you may be aware of this and been studying it. And this is a quick summary. As you saw, the money devolved to the different systems. We have integrated care boards managing the funds. And we are now looking at a system that's usually around 1 to 2 million population. And even that is a big number to manage. So they're then made up of places within that, which is usually around 250 to 500,000 people. And even that is a daunting number of people to take care of. And so it's then evolving to break down into neighborhoods and different networks, which is at the primary core level, people call it primary care networks, and they tend to be in the 30 to 50,000 population. So you can see how the Lego pieces add up into the total piece. We need to see the total view, but to make impact in reality on the ground is broken into coherent parts that are reasonably in scale, but not too big to be not personable or deliverable. So this is how the construct is emerging in the UK. Again, as I mentioned earlier, there is no perfection in healthcare, but we are all a work in progress. And I'm pleased to share some thoughts on a vision of what a new care model could look like going forward, especially when it's rooted from a primary care lens. Now, wouldn't it be fantastic if every citizen or patient has a clear single point of access to care? Right now, there's always a lot of complexities on how you navigate and enter the health system. So a single point of access 24/7, day or night, would be a very core foundation to have. Wouldn't it be great where care would be much more personalized? So a patient is not just a number. We need to move more to that. There's a lot of care that is delivered in secondary and tertiary institutions. And they have a fantastic and important role to play in the health system. But wouldn't it be great if care, right care, can be delivered closer to home? There was comments made earlier about people serving, helping people, and that is spot on. Wouldn't it be great if we have a profession that or professionals in the health system has a chance to thrive, not just because they're helping people every day, but they can develop their skills and have a very fulfilling career. And let's not forget the population. I think that it is important that we empower the citizens, communities, to take a bit more care of themselves, and to move the needle on prevention. And so these are very key principles that needs to be embraced for a sustainable care model for the future. For us, there is no one perfect way, but we do try to look at the populations we serve based on risk. So if you look at this diagram here, if you try to segment the population, you will have a lot of people, you hope, who are well, and you're focusing on keeping them well. You will have people who need some episodal care, things happen, but not too serious, not life-threatening, but you want to have a robust primary care there to support them. You will also have people with burden of diseases, and some people have multiple conditions and comorbidities to manage, and they increase in complexity that you can't just treat them per normal. They need that extra little help, different kind of help. And there's a way in which you can look at these care management buckets from condition management to advanced illness, where there could be differentiated levels of support. And then last but not least, bad things do happen every day, accidents, many things that are not pleasant, and you want to have a very responsive secondary care unit there to support. But even within that, there's innovations that can take place, step down, hospital at home, intermediate beds. So there are many opportunities that makes up the whole ecosystem. But this could be a really interesting way to segment and look at how care should be delivered across the system. And of course, the main thing I wanted to share on this slide is primary care is a very important nucleus core to an overall health system that connects together.
So I'd like to describe to you what general practice looks like at the ground level in the UK. Our family medicine centres are all located within communities. So in general, we've been within our communities in the same place for decades. My practice that I'm currently working in was established in 1968, and so has been embedded in that community for a very, very long time. The patients that are registered at my practice have been there with us since birth, a number of them. And I think that's our unique selling point, that we provide care from cradle to grave. And so the patients who come to us as babies, who we start to vaccinate, we then leverage their care throughout their life so that we can adapt to all the different things that they need. So as we've got young people coming through, we can give them the immunizations they require, we can give them all of the mental health support, and then give them preventative advice on keeping themselves well throughout their life. So we are very much there for the community, serving the community and understanding what our particular community requires. So my practice at the moment has a very high level of mental health patients. So we understand that, and we have extra mental health support within our team to ensure that our patients get the best care. We never turn people away, no matter what they're asking us for. So we always say that no problem is too big or small to bring to us, because every contact with our patient counts. It helps us to build a long-term relationship with our patients, which in turn helps us with shared decision-making, ensuring we have patient preferences at the core of what we do, and that we enable patients to have the confidence to come to us with their health difficulties earlier rather than later. So our patients can come to us, they can telephone us, they can make an appointment with us online, they can turn up on the front door and book an appointment through reception. So there's very many different ways in which they can access us, and we can also access them the same way. We have the ability to use digital technologies to send them information too. So as I was talking about, the family is the core of what we do in primary care. There's a number of people on this very extended family here, and I'd like to just talk a little bit about the youngest and the oldest, because I think they definitely represent a significant amount of what we do. So if we look at Pedro, Pedro is 80. He's been a patient with us for many, many years, and we know him and we understand his needs. He's suffering from dementia, but we've known him from before he had dementia, and we understand what his concerns are about his life beyond when he can make his own decisions. He's got a number of health conditions for which he takes a number of different medications. But what he's told us, when he was well enough to, he's told us that he wants to have dignity in death. He wants to have a reasonable death where he's at home, looked after by his family, with support from care workers. And he's told us that he doesn't want to have resuscitation and he doesn't want to be admitted to hospital unless it's for something that can be acutely cared for and he can be returned home. So he does not want to spend prolonged time in hospital. I can hold that information with my computer systems. I can pass that information on to other care agencies within the UK so that I can help Pedro and his family achieve the death that he wanted in the most comfortable manner at home. If we look at Marta, Marta is 6. Now, she's in this very, very busy family. And you know, we all have very busy families with busy lives and busy work. And sometimes the youngest might just get a little bit overlooked because everybody's busy. So Marta is a little bit shy. She's not sure about how to make her voice heard. She's having the same difficulties at school where actually she's being a little bit bullied. And she's also losing weight because she's unhappy. She doesn't know really how to call out for help. Her parents have noticed that she's potentially self-harming. If they come to me, I can help them deal with the problems that Marta is having with her mental health. I've got access to mental health services where we can provide support, but equally I can also provide support to the rest of the family in helping Marta achieve her full potential. We talked a little bit in the video about all of the different teams that we have within our primary care networks. The most important thing, I think, for us in terms of looking after our patients is providing continuity of care. With continuity of care, we begin to really understand our patients, what their patient preferences are, and how to give them information in a way that they understand. You know, some patients will understand written information better, some patients will understand visual information better. But if we get to know our patients and how they interact with us, we're able to provide much better personalised care for them. So our multidisciplinary teams work around having a core of practice professionals, such as a GP, a practice nurse, a healthcare assistant, similar to a health coach, a management team around them. But then we also have, overriding this, a care management team that provides care for the planned care. So for complex long-term conditions or for people with multiple long-term conditions. And those multidisciplinary teams will work within each of the smaller teams to provide an extra level of care coordination. Through through the multidisciplinary teams, we try to provide our patients with a very personalised journey. Every time a patient comes to us, the answer is not always give them a pill or send them off for surgery or have some form of an intervention. What we're trying to do is we're trying to enable patients to live healthy and happy lives without sometimes the need for those interventions. So demedicalizing is extremely important, really trying to understand through shared decision-making, what is the patient's preference? So, for example, if you have a patient who you know has got osteoarthritis of the knee, it may be that actually they don't want an operation. All they want is to have some physiotherapy so that they can get up and down the stairs reasonably. They know they're going to continue having a bit of pain, but actually they don't really want that operation. So our job there is to enable that patient to have the personalised care that they need to keep them functioning at home. So our care cycle looks at patients, looks at what they particularly want to achieve and enabling them to be able to reach their goals in a more sustainable fashion. In all of this, the beauty about general practice is that the social determinants are not forgotten. I know that my patients have recently had grandchildren who don't live with them, but they come and visit them, so that the time their grandchildren come to visit them is really important. And that is the time they don't want to be disturbed with health coaches or with appointments and things like that. Or they've had the death of their loved dog that has been with them for the last 30 years. That's going to affect their mental health. So by understanding what's going on in the home, I'm able to provide them with a more personalised journey through their health. If I could give you an example of one of the things that we've been recently pioneering, I expect that in Peru you have similar issues that we have with rising incidences of diabetes. Some of that is related to, well, a significant amount of that is related to lifestyle changes, where people are becoming more obese, more sedentary, eating ultra-processed food, so that we're leading to something called metabolic syndrome. Now, this is something that's happening across the world, and the UK is no different in seeing the changes in the number of people who are getting type 2 diabetes. So using a set of health coaches and an app for patients to support behavioural changes, we've been able to give patients lifestyle advice personalised to them so that they are enabled to make the changes they need to make. Now, the changes that they are making are very personal to them. So the coaches will discuss with them exactly what it is that they feel is going to be most important for them, and will track their journey with regular contact with them, remote contact with them, and also contact through the app. This is all supervised by physicians who obviously ensure that the advice that is being given by the coaches is evidence-based, so that we're following good guidelines on supporting patients, and that we are able to ensure that if they make those changes and actually things like their diabetes start to improve, we're able to reduce the medication that they're taking to, again, demedicalize what is happening to them in their health journey. We've also started to think about incentivizing patients to join us in supporting their lifestyle changes, considering different rewards that we might be able to give them. Obviously, healthy rewards. We're not going to give them access to pizzas for life, but we'll try to work with them to see what it is that they would appreciate to enable them to join us on this journey. So we've been running this program for type 2 diabetes. And we are beginning to see a number of different results. So we've been running this program for about 18 months now. And if we could move on to the next slide, Vincent, I can show you some of the results that we've been able to show from this. So there's much more of an understanding now that lifestyle changes without any medical intervention will cause a huge change in patients' medical conditions. So if you look at the programs that we've been running, we've achieved reduction in body weight, reduction in cholesterol, reduction in waist circumference. But for me, the biggest change as a doctor is that we've had an 85% reduction in these patients in their use of medication. So we have been able to, in some cases, reverse their diabetes so that they are on no medication just through lifestyle changes. I mean, I say just through lifestyle changes, but these are fundamental changes to the way people live their lives, the way they eat, the way they exercise, the way they go to work, everything they do, they have made a huge change in what they're doing. We're also working towards having a much more embedded, digitally enabled access to primary care. So we continue to use the multiple channels that patients are used to using. So they can still telephone us, they can still come and talk to us at the surgery to make an appointment. But what we're using are digitally enabled triage so that patients can be directed to the right person at the right time. So essentially signposting to the right type of appointment that they need. And as you can see, we can split our digital triage up into things that require administrative support, things that require planned and unplanned care, and obviously anything that is an emergency, the triage forms will automatically say that this is not relevant for us, that patients must contact A&E or ring 999 for hospital advice. Through this digital transformation that we are currently undergoing, we're also able to digitally deal with blood results and any other test results that are coming through to us so that normal results can be filed without access to a doctor, and some results so far we've been able to action using our clinically led protocols without them going through doctor checking. So if I give you vitamin D as an example, where we have patients whose vitamin D levels come back as showing that they have insufficiency, we will send patients messages to say, you must buy some vitamin D over the counter, which is the UK's preferred method. But if you are vitamin D deficient, we have provided you with some tablets, and that will happen automatically without the doctor seeing this. The doctors have devised the clinical protocol for this, so we know it's safe, and obviously we do regularly audit the clinical protocols that we have. We talked a little bit earlier about regulation within the UK, and we are regulated by the Care Quality Commission. We call it CQC. They are responsible. The government has given them the responsibility for regulating all healthcare within the UK, so acute trusts as well as primary care. They assess us in 5 areas. They call them key lines of inquiry, so we shorten that to a CLOE. And as we've written the 5 CLOEs that they assess us on: safe, effective, caring, responsive, and well-led. Within each of these areas, they give us good guidance as to how they want us to deal with our patients. It covers not just clinical care, but it covers premises safety, it covers medication safety, it also covers the well-being and the safety of our staff. So we spend a significant amount of our time ensuring that we fulfill the requirements of our regulator. We talked a little bit about primary care. I consider myself to be a specialist in generalism. So people can come to me with a number of different conditions, and I'm still able to either to deal with this in my own surgery or to signpost them to the right person for treatment, further treatment. And this path shows you the training that all GPs in the UK will have. They'll have their medical degree, they'll register with the doctors regulator, the General Medical Council, they'll do their foundation training, and then they will do specialist GP training. And specialist GP training in the UK goes on for 3 years, 2 years of which is spent in hospital medicine, and then a year is spent in primary care with a primary care trainer. And then our doctors are required by the GMC to take the membership exam of the Royal College of General Practitioners before they can become accredited as a GP. We've recently launched a program with the GMC whereby we are able to provide general practice training for 1 year within our practices using, as Vincent said, our significant number of GP trainers for international students, and we're currently able to do that for any country in the world, so that the students who would like to join this program have to have already fulfilled a number of conditions that the GMC require. But once we've interviewed and assessed that they are suitable for entry into the UK system, we can then put them on our training program for specialist GP training.
Thank you, Mina. I think every time you talk about pizza, I get upset because I do like pizzas a lot, but I do take them in moderation. I am going to cover a few more slides looking ahead on what our views are, the progression of general practice in the 21st century. And you will find, if anyone could guess, looking at this slide, what my favorite letter is. It is the letter P. So we'll have some fun as I go through some slides, but it won't be hard to miss the letter P right throughout the remaining slides here. So we believe that the future, surely, right, looking at the different advances and pressure points, we must really do more and better in proactive care. We need to figure out earlier detection. We touched on prevention, which I think Mina beautifully described different ways in which we can make things personalized, incentivize people to change. And isn't it better to prevent than to be dealing with the severity of the different conditions and the symptoms? So we must be able to prevent, and actually now with genomics and whatnot, we can be a lot more precise as well. So I think these 3 Ps would be quite interesting to monitor and to really invest and advance on in any health system. Now, we talked a lot about patients, and you hear me talk about citizens as well, but I think we should change the language and say care delivery of the future should be person-centered. So this little diagram here is just a different way of reflecting what Dr. Mina was talking about, where we have the person at the center. It's not just always about health. There are other factors. It's about eating better, being happier in relationships, sleeping longer, and using technology proportionately with that. And why not if you get rewards for good behaviors as well? So imagine an ecosystem connecting all the pieces up. And that surely must be a way forward in our vision. I don't know what it's like in your respective health systems, but we find in many countries, the health systems have many divides. Someone is always pointing the finger somewhere to say, hey, that's not my problem, it's your problem, or who did who to what, right? And so the future for sustainable health system needs to be about promoting more integration. And here we have more peace. It's about people, it's about process, it's about pathways, and then it's about the platform. So if we can align looking at these elements, more good things happen than not when you can do that. And I know it's also much easier said than done, but we have been successful in trying to close some of the divides that does exist in the NHS, and we will continue to be champions of that together with our colleagues. We talked about the team. We got to have high-performing team members, and it is super important to track how we're doing, well-being. You cannot believe the number of burnouts that's taking place, because in the profession, the care profession, people are taking a lot of burden, looking at the patient, listening to them, helping them, and it's a lot to take on. So we need to make sure we're always looking out for our own teams, because without our own teams, there'll be no service. So something that we've been investing and coming up with a lot of different fun ideas to make the workplace happy, and that's very important. Part of being happy is not just about working in a place where people are nice, kind, but imagine being able to thrive in your profession, being able to get trained, upskill, to get to a higher license, and to work at the top of a license. Again, I want to reiterate, we are not perfect at modality, and by no means in the NHS either. But these are some key cornerstones, key principles, or training capabilities that we have in place and we continue to add to help advance the careers for our team members. I always say healthcare is a team sport. You want everyone to show up, play in their positions, play well. And how about having patience in that team too? Because I think as a profession alone, you can't win on your own. You need the public. You need the patients in their understanding and playing their part. So over the years, we have made progress. We've done different interesting things to engage patients, and you can see from the pictures, you know, from pre-COVID days to during COVID, and we continue to work on trying to be creative to engage our populations. And then more peace, private-public partnership. So many of you may not know this because it's not a well-known fact. When the National Health Service was born, now 76 years ago, general practice, you know, the village doctor, the general practitioner was born then too. And we, Dr. Mina, myself, and our other partners who owns Modality, we are private providers. We're independent contractors, but we hold this public ethos because we hold lifelong contracts with the health service. So even though we're private, we are public. And that is something that is quite unique, but important, I think, for many health systems looking to transform, because there are pluses and minuses, isn't it? When it's just looking at the public sector lens. There are also pluses and minuses when you just look purely on the private lens. But what if everyone knows that they're on the same team and figure this out, looking at funding and different risks, working that through? Because I think PPPs are quite important and a key driver for any systems looking to transform. And let me close with another P, which is positivity. I believe there are always challenges facing the health system and all of us, right? Every day, there's not a dull moment. But if you take a positive mindset, if you focus on producing, not perfecting, if you look to get more people involved with promoting participation, and let's not be afraid to make mistakes. It's not going to be right all the time. And when it is not right, pivot, figure it out, be honest, pivot, and aim for the right direction if you're off track, and then keep pursuing excellence. So thank you so much for listening to both Dr. Mina and myself. We will be delighted to take any questions, or we'll turn it back to the MC. Thank you very much.
Muchas gracias, querido Dr. Vince, querida
Thank you
doctora
very much, Dr. Vincent, Dr. Mina. Excellent ideas shared. A very motivating experience, very clear-cut ideas emphasizing on primary health care as the mainstay of the health system, and the emphasis put on focusing on the people, on the person, on the family, by paying attention to their needs with a perspective of life. Well, thank you very much. Once again, we would like also to thank those people who are connecting through social media. We thank you very much for your comments. We've received a lot of congratulations and salutations, and we ask you to stay in the room because we have received many, many questions. Now, for comments, we would like to give the warmest welcome to Dr. Catalina Ascano. She's an advisor to the Vice Minister of Social Protection of the Ministry of Health and Social Protection of Colombia. Dear Dr. Catalina, the floor is yours. Please speak slowly, because we need to guarantee an adequate interpretation. Well, good afternoon, everyone. We are very grateful because of the invitation, and the first thing I would like to share with you is the Vice Minister, Luis Alberto Martinez, had the intention to be here with us. Unfortunately, he couldn't. He had a last-moment appointment, but I'm here on his behalf to listen and learn. The truth is that we've heard a very interesting and moving presentation. We all felt that they were relating a dream, something that it's actually something that we would like to implement in our health systems. As you know, we right now in Colombia are implementing a transformation of our health system. Our primary healthcare services been scarce, and we would like to reorient the health system and focusing mostly on primary healthcare. And we have lots of questions. And to kick off this conversation, I would like to ask something that it's very important: how to allocate the resources for this first contact with the healthcare system to be robust enough, this robustness that you've described, because there's always a fight, a tension between how much to allocate to primary healthcare and how much to high complexity cases, as if these were two opposite things. Well, in the truth, they share many things. And this 10% that you've mentioned, I would like you to explain a little bit more about this 10%. How is it managed, and what is included in this 10%? It is absolutely wonderful what you mentioned about thinking, because the fundamental challenge here is to establish long-term relationships, and we need to build this well-being there. When I think about the long term, I have to think about constant funding, something that need to be sustained and not succumb to the economic cycles. It should be there all the time, infrastructure, technology, and so on and so forth. So we are talking about a long-term relationship. So I would like to learn more about the relationships, the transitions, the interactions between the service rendering, how to provide for healthcare services together with educating and training talent. What's the place of academia here and research? Research in two senses here. One, as to how to fund this research and what's the place of this research in the daily lives of the workforce, and how to pay back the community, which will get their problems solved, but also about the decision making, the ministries of health. Could you, well, I could have more questions for all of you, but these are the first questions I would like to ask. I'm very moved by your presentations, and you showed very interesting figures in terms of the impact and the results. That's why I'm going to say that I'm really thrilled with what you've shared with us. Thank you very much, Dr. Catalina. We would like to hand the mic to Dr. Ciro, please, for his comments, and then we would like to listen to the speakers answer this. Dr. Vincent and Mina.
Okay. I've
understood everything very clearly. This is a dream that we also share with Dr. Catalina. We are always concerned about financing, but an intelligent and honest financing is possible. It's possible to reach this dream that we all have. And we've thought about this, say, from cradle to grave, well, from cradle to grave. Well, this is actually Pachamama in Quechua. And I would like to start with my comments. We were wondering about the hospital of the future. And now, after seeing your presentation, we are not only focused on health, but to have happier people, more educated people. And it's not only about a Star Wars hospital, but something that's in the community that will extend lives. For what I've heard, the big solutions to the big problems of today and tomorrow, as the epidemiological transition that we have with the chronic diseases, it is about changing our lives, the way that we live. Actually, this is a vision that we share, and something important that we've always done, and this is the dream that we have, to aspire to what you do, to be person-focused, person-centered. So data should be digital at the point of care. That's where they need to be born, because digital data might be transmitted somewhere else and might be also analyzed, and we can process those data. If they are born in a paper, they will die in a paper. And we have a lot of graves of data. And I think that the digitalization at the level you've explained, it's also a dream that we have. And this data will help us implement tailored or personalized medicine. And in this way, we will know how the people will behave. And this is the other dream that we have, that the data will let us know about the profile of our people. If we take the data of those children who are being born today, we are taking data to make decisions next century, because the children will govern and take over our powers next century, because they have a life expectancy of more than 100 years. So let's not stop working on this. And something that I liked very much is the peace. And I would use another P here, which is financing, which actually does not start with a P, but this is for public well-being. If we use it wisely, honestly, and amayuya masua, as we say in Quechua, that means that we shouldn't be lazy, we shouldn't lie. If we do this the way that you're doing it, we can learn a lot as a country, as Andean countries, and you as the UK, who also have a cosmopolitan citizenry, we can once again have a better world. Thank you very much. I don't have questions. Everything's been clear cut. This is just a comment. It's a shared dream.
Dr. Vincent, Doctora Mina, les cedemos
Dr. Mina, Dr. Vincent, the floor is yours now for you to comment or answer the questions and comments that you've received so far. The floor is yours.
Thank you very much. This is our dream too, and we are a work in progress. Again, I want to reiterate that no health system, even with the history of the National Health Service in the UK, has solved everything. But at Modality, we are working at it and trying to put all the building pieces in. I think it's very important that we're here to share, but we're also here to learn. So I want to ensure all colleagues or people in the audience know that what we share is what we think is possible, and we've made progress, but we need to bespoke it in your respective countries, bring the best practice and the principles of it. Lifting and shifting will be a complete immediate failure, right? So what I've learned, especially with some of the work we've been doing in Vietnam, where we are trying to pull together a British-style integrated care system, is when you don't have so many years of almost the culture where people know in the health service that you go to the GP. I think in many countries, the GP is not even seen as the highest, the top grade doctor. So people will say, hey, I'm going straight to the specialist. And Mina's point about being the specialist of being the generalist, that's really important, but the public may not understand that. So I think that, Dr. Catalina, your progress or your work, it'd be fascinating to trade more notes on that, because if anyone's trying to replicate the British NHS primary care system, do we really have 75 years to figure this out? I don't think so, right? And we certainly don't have that much money all around. So there are things which we believe through lifestyles, care management, patient engagement, there are very targeted opportunities where you can get, I believe, cash realizing impact, cash realizing savings that is much needed in every health system to then pump prime to invest for the next thing. So to just say, let's open up general practice, if it's not something that's common, let's make everyone go to it, it will be too slow. So I think there are different ways in which we want to ensure your care model is tailored. And one approach of thinking about that is how much is your population based on the risk segments? Are you looking for transactional care? You know, it's a very quick question. What is it versus, as Mina said, the continuity of care where you need that different grade of support? Because if you could segment this out, you will be able to balance your budgets differently. Yeah, you will know, like at Modality, we have frequent attenders, similarly to frequent attendance in hospital settings. I think we have 11% of our population taking up 47% of appointments. Is that right? Is it equitable? So, you know, by using data, by looking at utilization trends, by understanding the needs of the population you're serving, there is a way to find sort of the right bucketing. And remember, we are primary care physicians, or you know, so we are biased. I would argue, even in the UK, too much funding is going to secondary care, right? Of course, I would say that because I'm the primary care sector, but to put everything into primary care is not correct either. So, you know, because everyone is in the game together, so no one's out to kill anyone off, but it needs to be proportion and balance. And I would also include the insurers. I think there's private insurers in the mix here that, you know, if they suffer, you know, is this balloon? If someone thought they won, then someone has lost. It never lasts. So I think there are things that can be worked through. And my advice would be to take it in really tangible steps where you can prove out. And you mentioned research. Can you imagine if we did a pilot study together, right, where we can say, let's go for 1,000 patients and let's try the formulary that Dr. Mina talked about with diabetes. Let's try that directly. And we have 500 patients that is eligible and they're in the program, and another 500 that isn't, right? Do a control trial and see. Because if we know we're onto a winner and it's correct, let's say in Colombia or in Peru or in Brazil, then you tailor it, you know, and then you scale. So, but let's start, because I think a lot of times the complexity is, do we have enough money? It helps to have money. But it's usually not just money. There's mindset. People saying, no, it can't be done. We're too busy. So can we create an environment where we are testing this out like properly? And Mina, can I bring you in about the governance and safety on these aspects of change? Do you mind sharing some of those?
Absolutely. So one of the comments that Dr. Catalina made was about academia and where does that fit? So actually, if you're delivering these kinds of programs, you need to make sure that the coaches and the doctors are delivering evidence-based medicine. So the protocols that they work from have got to be robust. Now, your evidence-based medicine may well be slightly different to what the UK uses. And so everything that transfers over has to be formulated for the appropriate country that it's going to be based in. And then once you've established your baseline training, you then need to carry on and ensure that the training, that people don't slip in their standards. We do a lot of work in terms of making sure that the advice that's being given is still being given correctly. You know how people slip into bad habits about how they do it. You also want to make sure that there are no contraindications, that people have, you know, say you've suddenly, you've achieved all your behavioral modifications and you no longer need to have your metformin. If nobody is there to actually stop it, you're going to have difficulties. You know, you're going to have low sugars and that's going to cause you problems. So there's a lot of wraparounds that need to be put in place for even something as what looks on paper quite simple. But this kind of project, I think, you know, at the end of the day, this is, we would consider in primary care, this is a low-cost intervention. This isn't a big shiny building with lots of ventilators and operating equipment. This is very low cost in terms of using doctors and health coaches and remote platforms to do it. So this I feel from what I've done in medicine throughout my career, this is sustainable. It fits everything we're talking about in terms of climate change and the green economy and everything. You know, you are actually saying to people, change the way you live to make the difference in your life, and it is going to make your disease process better. It's such a game changer.
Muchas gracias.
Thank you very much.
Thank you
dear
very much, Dr. Vincent and Dr. Mina.
We're going to
We will
continue
continue with the dialogue
discussion.
now. And
Before
before,
that,
we would
we
like to
thank
thank all the people who are in the room and also
those who have
the
joined
people
us
who are
from
connected
Bolivia,
from
Brazil,
Bolivia, Brazil, Cuba, Chile, Colombia, Ecuador, Mexico, Paraguay, Uruguay, United Kingdom, Venezuela, El Salvador, the
United
US,
States,
Spain.
among other countries.
Thank you
so
very much.
We would like
We would like to know if
somebody who's
any
in
of
the
the
room
people who are here in
would
the
have
room have questions, please. This is the time to ask those questions because we have some questions which have
sent by people who are
arrived from the
connected
people
in the
online.
webcast.
Please, those of you who are in the
Those of
room,
you in
if
the
you have
room, if you
any
have any
question,
comment or
please
question,
introduce yourself, say where you work
your
at, and
institution,
give your
and then
comment
make
or
the
question.
question or comment.
Bueno, muy buenos días con todos. Muy buenos
Good
días, señor
morning to
ministro.
everyone. Mr. Minister, good morning to the panel members. Vincent, good to see you again, and to all the people present with whom we usually meet. We have seen a concrete proof of something that can be real, and that definitely can also be real in our country. I have no doubts. I think that the Peruvian model is something that we are building together as a team. We spoke about a dream. I'm happy, Vice Minister, to hear that it's also your dream. Certainly not all dreams can be achieved, but there's nothing that we can achieve if we don't dream first. So we are already dreaming something and we are in the track of achieving it. On the other hand, yes, you've shown by Vicente and Mina has shown many P's. There's a P I don't like, which is poverty. And that P is the one that moves us and is a challenge for all Peruvians. Now that we have almost 30% of the population in poverty and extreme poverty, make health with good quality services. As a controller, official controller of the country, we take care of the public resources. And the first level of care is 30% of the budget, and 96% of the 9,500 health posts are at the first level of care. 50% of level 1-1, where we know that there's no physician, and there is where the private sector.
Oh. No, I can't. If you want, I can speak in English. Okay, sí, por supuesto.
Yes, of course. 50% of the public institutions are the first level, and it's level 1-1 without physicians. That is our reality. And in the private sector, 64% are the first level of care. So we have an expansion of infrastructure, as it has been mentioned, but we need to start learning and starting those engines, those machines that we need, that all Peruvians have, because we have dropped the index of competitiveness. We are in position 63 of 67 countries, and that makes us less sustainable for the future. And there's informality of almost 80%. People don't pay taxes because we, in order to incentivize,
Better speak in English. Better. Para poder incentivar.
In order to create incentive for people to pay taxes, like in the UK, because there's accountability, we need to provide quality services. So if we want to make something for the country, we need to look at what services we provide, and health goes directly to human capital, where 35% of competitiveness is present. Well, as a general controlling office of the country, I show a lot of data, but this is what I consider that is core. But there's something that gets us all together, that we love our country, and I think that's the most important value, to put health first. We've been meeting for several years. I've met all of you for many meetings. I think that this is the time to do something, the big change, and that is the love for our country, and go through what the Vice Minister has mentioned, Quechua language. We have 4 million Peruvians speak Quechua, the local language, but the state has to be there and help this population where most of the extreme poverty is concentrated. We need to speak in their language. I think that is a responsibility not only from the health sector, but starting in the health sector to communicate with the population. Thank you very much. Thank you. Somebody else?
Por favor, recuerden presentarse, el nombre y la
Remember to
organización.
introduce yourself and the organization that you come from.
Buenas tardes, Nancy Serpa.
Good afternoon, Nancy Serpa. On behalf of the Vice Minister of Public Health, Dr. Eric Peña, I bring his greetings, and he apologizes he's not here. He's well, thanks for the invitation, and by listening to Dr. Vincent's presentation with regards to the model of primary healthcare. Well, it only ratifies the Alma-Ata Declaration. One of the aspects where he pointed out is this outcome with the change of lifestyle for diabetic patients that only prioritizes and positioning prevention and demedicalization of health. I think that that is something extremely important in your model. You mentioned the relevance of the family doctor, technology, comprehensive care, care networks, and the integrated systems, which are all the components that we consider in primary health care, and that somehow the model in the country takes into consideration. Perhaps we need some order, some direction, but I think that in all these aspects, there's small progress of which we can find at the levels of health services. And I consider, and has been mentioned by Dr. Vincent, is the multidisciplinary team effort. It's extremely important. We find inside the country, in the countryside, how the multidisciplinary work is coordinated and integrated. We make progress. A few days ago in Belén Pampa, in a health post in Cusco, the initiative of telehealth, not only there, but also in Cajamarca, how the coordinated effort and very close work of the multidisciplinary team makes the patient feel satisfied with the care provided by the health staff. The family doctor of Belén Pampas said, "I don't reject any patient." And this is the expression that I have from Dr. Vincent, where he said, every contact with patient counts. And this is something that I think our teams should learn, and we should motivate so this can work in each one of the initiatives. In telehealth, this doctor mentioned, they come or they call me, and if they come, we need to see the way of have a on-site visit with a specialist, because they're going to allow us as health services, as health providers, to close the gaps in unattended demands with non-transmissible, especially. And in this transit of the Alma-Ata to the Declaration of Astana, it is clear that primary health care, it doesn't mean first level of care, because what primary health care looks continuity of care, and therefore we need to integrate the hospital level or higher complexity level. Those are my comments. Thank you very much. Excellent comments. Thank you very much. the people who are present here. Now, Dr. Vincent and Dr. Mina, and then we will read some questions that have arrived. There are many questions that have arrived from the people in the web, but we'll have to select them. Go ahead, please.
By the way, I love the energy and passion, and that's what I've always found in the region, the warmth of the people and the population. And I think part of your secret sauce could well come from that population and activating your communities. So I think the true value of the exchange is how we can turn some of these concepts into reality in your own local setting. And I could see there are different elements here that has significant potential, but it will need, the answer lies actually in your rooms where you are. You know, we have examples, scars, what we've done right, what we've done not so right, but we could be a really good critical friend to the different countries and the systems trying to embark on this ambitious journey. And it is worth it, because if you can't sit still and do nothing, and doing nothing is not an option. And I think that is the same in the UK as well. So what better way to really exchange, build something together in a sustainable way. So thank you for those comments. I hope that's helpful. I know there weren't questions per se, but I just wanted to reflect that I could feel the energy and the importance of getting this right.
I would also agree with what Vincent is saying. You know, the answer always comes from within, doesn't it? To take something ready-made off a shelf is never going to work. And it's actually looking at where your strengths are. And as Vincent said, the passion that is coming through in terms of wanting to be the change maker is what I think will be the differentiating point for success at the end of this.
Muchas gracias por la respuesta.
Thank you very much for the answers. I'm going to read some of the questions that have arrived from the people that are joining in social networks. There's many comments, congratulations, and questions. One of the questions has to do if there's any policy for incentives for human talent that will contribute to primary care in health. There are several reflections in relation to the problem that we have in our region of limits in human resources in health. What message would you give us in terms of human resource? How have you done to expand a larger number of people that are hired for primary care healthcare? The experience with homes and elderly is extremely interesting. Are there any publications related with these topics? Can we have access to them? And how? I think I'm going too fast. Another question, and then we'll give you the chance to answer. How does the referral system works in the UK, referral and counter-referral between the first and third level of care, and how are the comprehensive care provided in the third level of attention? Thank you.
Shall I
go ahead, Dr. Vincent?
Go ahead, Mina.
Okay. So I'll answer the second question first because it's relatively easy. The way that the referral system works is that if we feel a patient needs more enhanced care than we can give, we refer them to the secondary care sector. Now, we have established referral pathways through our digital systems. So I don't need to send a letter anymore. I send an email from my secretary to the secretary of the specialist, and that the patient is then sent an appointment. If the consultant feels that this is the wrong speciality for them, in some instances they will continue the referral to another specialist, but in some situations they will send the letter back to us and say, the patient wasn't suitable for me, you will need to refer them elsewhere. Some of that is a contractual issue, in that what was happening was that hospitals were doing a huge amount of work with consultants referring to consultants, and there was large volumes being generated there. So this is in an attempt to try and reduce the volumes that are being seen in the hospital network.
Shall I touch on the policies or talent management side of it? Again, this is something that is key, right? If there's no people, there's no service. I know in the UK, there's a lot of thought put forward on our long-term plan to increase capacity. But let me just speak specifically from a modality standpoint, what we are working on. And I think this should resonate with everyone in the room or in the audience. Do you want to work in a place? And why do you choose to go to work, right? We do that to pay bills, I assume, right? But wouldn't it be nice if you went to a job that paid bills, but then you also got something else on top in return? So for example, you get to grow professionally. You're working in a nice place where you're building bonds, friendships, and then you're helping people every day. So there is a way in which you can find talent by making sure they will be valued because they are important. So the ideal people we work with, and both Dr. Mina and myself, we're workaholics in it because we don't actually see this as work because we've chosen this to be our vocation. So, and this is not to suggest work-life balance is not important, but imagine a workforce where they're motivated because they're fairly paid. But on top of that, they're getting enrichment, fulfillment because they're working with colleagues, helping people. And this is really their life's work. If you find that, that's very contagious, right? In a good way, because then you say, yeah, I want to be part of that. I want to be part of that because I am the community. I am the heroes helping people every day. Now, what happens in the health system is this also too hierarchical. So yeah, if you're not working as a top specialist in the hospital, you're not important, So we need to understand and present ourselves to say everyone in the primary care system to the public that it is a very key role that they play in the community so that people can get recognition, their own recognition, if you know what I'm saying. So I think there's something there about making sure people are valued. And it's not just about money, it's about money plus, because that will be what will last. I hope that helped.
And if I could just add that we've increased the workforce quite significantly in the UK using the multidisciplinary team. Our problem has been that we've had very few GPs, and the situation is changing in the last year, but for the last 10 years, the number of GPs staying after training in the UK has fallen and fallen, and they are going elsewhere. They are going to Australia and other countries to practice. So we've had a falling GP workforce. And because of that, we've had to introduce new roles such as the pharmacists, the physiotherapists, nursing assistants, all sorts of different types of people. And the biggest difficulty with that has been actually with patients. So we have to get patients to trust these multidisciplinary team members, trust them enough that they will provide them with the right care, that patients feel secure with them. And part of that, the way we've done it, is through our multidisciplinary teams, where you will always have that GP who is overseeing what the other healthcare providers, healthcare workers are doing, so that everybody feels that they are contained and nobody's being lost within the practitioners within the system.
And if I may add just one more thing, I'm conscious of time as well, is let's not forget the role of technology. So can technology be another way in which we can really exponentially increase capacity on diagnosis that is more transactional in nature, rather than needing that attention of the face-to-face continuity healthcare support? For us, we have programmed our own automation bots to actually improve the working day for the team, because there are actually a lot of administration that clinicians and our team members have to deal with. So if you're the policymaker or the transformation lead in your respective countries, spare a thought as you redesign on what administrative burden has come with it. Because I think at one point we had almost more than 40% of our clinicians' time is spent on admin. You want the clinicians to be seeing patients, not doing paperwork. So, but again, with the advancement of technology and proportionate technology is important, not just the most fancy ones. You need to be proportionate. Using technology can really save time and actually improve the enjoyment of the work. If you came to work and you have to spend all this time doing paperwork, and mundane, that's not good.
Se está escuchando la interpretación simultánea de los dos y los felicito. Realmente la interpretación es exactamente igual de los dos, pero sería posible solo escuchar una, por favor.
I'm sorry, we lost the translation on that. We'll need some help on that, please.
Muchas gracias, doctor Vincent, doctora Mina. Agradecemos las preguntas realizadas, los comentarios muy importantes.
Thank you very much for your questions and your answers. Many of the questions will have to be considered to define future webinars. We treasure and value the interest to participate. To close this space, I would like to ask Dr. Vincent and Dr. Mina for a final message, please. In 1 minute.
Thank you very much for having us. It's been an honor, and we have a lot to share, but also have a lot to learn. And I hope this is the one of many opportunities to work hand in hand together. We are up for very creative ways to create impact with you all. Thank you, Mina.
Yes, I would agree with Vincent. It's been an absolute pleasure and honor to be invited to speak to you all. I'd just like to share my enthusiasm for primary care. I'm a committed primary care doctor. I love taking care of my families, and I think it really is one of the most rewarding things that medicine has to offer. So I would thoroughly encourage you to think about ways in which, obviously, as we've said before, can't do the whole thing. There's no lifting and shifting, but actually making a difference to patients' lives, I think, starts in primary care.
Muchas gracias. Reiteramos el
Thank you very much. We would like to thank you once again for your excellent presentations, your magnificent ideas shared. We've received many positive comments on our social media. Thank you very much, Dr. Vincent, Dr. Mina, for the comments, Dr. Catalina, Dr. Ciro, all of the participants and the Horace Kono team, and also the people from the embassy, and all of the people who have been part of this activity. Truly convinced about regional integration and Andean integration, and also Latin American integration. Thank you very much to you all the participants. And to close, we now give the floor to Dr. Sara. Well, thank you very much, and good afternoon, everyone. I'm Sara Ante, Director of Trade here at the British Embassy. Just to close, during this past 5 months, it's been a pleasure to see how this webinar cycles organized in collaboration with the Andean Health Organization has complied this task of meeting our goals. We've reached more than 10 countries in the region, institutions, both public and private, universities and associations, all of them getting acquainted of such an important topic, oncology, primary care, reinforcement of many aspects for the embassy. It's been a huge pleasure to work hand in hand with the Andean Health Organization team, with Dr. Maria del Carmen, Marisela, Berta, Gloria, Yadira, Janet, and everyone. I'm sorry for my pronunciation, and the rest of the team as well. We are deeply grateful to all of you. And this also is a part of the comments by the ambassador. We hope that we will continue together and will solve and implement new initiatives. Thank you very much for your dedication. Thank you very much, Dr. Ciro, please. Dr. Sarah and all the attendees, thank you very much to the embassy for having all of us here and for sharing this knowledge. We will keep on dreaming, and many of these things are already becoming a reality. We're still having to face different challenges here. We have an outpatient program that needs to be implemented, but many of us have also been trained in primary health care. On behalf of the Cusco University and other academic institutions, I'm sorry, but I lost the audio. The microphone, you close the microphone, please. The microphone is off. So let's have this shared vision to have a better world. Thank you very much to the UK for everything. Thank you very much. We will hand the mic to Dr. Calle for the real closing of this meeting. Dr. Maria del Carmen. Thank you very much, Sarah, for being here with us. I remember the first contact that we had with you. We decided to go for it because we were interested. And we had this first contact and wondered why not to work with the British Embassy to bring experts from the UK who will discuss important topics and call for the representatives of the countries as well. Definitely, we've had more Peruvian representatives here on site, but at the media level, we've had a lot of people online from countries that go beyond Latin America. This is a super important cycle because we've dealt with topics that are very important for the Horas CONU. We've discussed the health systems. It was actually a very interesting topic. Then we moved to digital health, and we invite you to connect and take a look at it because the information that was shared was actually very interesting. We dealt with mental health, and we discussed about the different health levels. We discussed primary care, mental health, and then we escalated. And we had a webinar on cancer, which was actually incredible. And this is the cherry on top, I would say. Maybe you won't understand this expression, but yes, it's the cherry on top. And it is important because we are more in need. This is the region that needs to strengthen our primary care services. If we start sharing story, San Siro. I've been around for a longer time. I graduated in the 80s. I remember that I worked with Tessira. For you to know what this is community service. And I was lucky enough to go to a health center where my boss had just come back from studying a master's course on primary healthcare services. I've been working on this community service on 81 and 82. And we had the primary healthcare as you told us. We had 30,000 people under our responsibility, and we had records of each household with all of the members of the household. It was incredible. And from that moment on, and we've been discussing this with David Tejada, this was not a primary healthcare. It was cuidado in Spanish. In Spanish, this entails the participation of more people, not only the doctor, not only the professionals, but also more people being engaged. Now we speak about social determinants and trade determinants. We are at a different moment now. But what's concrete is that we still spend more at the highest levels. And it's been proven that most of the money is spent in the last 6 hours of life. And we have an agreement with Denmark. We have discussed this topic at length, and we are truly convinced that we need to have a really worthwhile primary healthcare service. I loved your piece, Dr. Vincent, but it reminds me of pizza because I love pizza. And you said very interesting things. Proactive early detection. This is something that you mentioned. We can solve lots of problems with this detection. Then prevention. Lifestyle choices also, but we have to give them possibilities to choose the best. Because if I say, yes, you have to improve your diet and you have to eat vegetables and they are very costly, it makes no sense. We have to create the right environment. And something that I liked the most is precision, tailored, according to, based on, each person is different. Each person has different wishes and expectations and different needs. And it is super important to know that these are different, because people believe that one size fits all and that you are taking over others' needs. But this is not what it is like. Sometimes this is not what someone would like, would wish, or want when they go to a consultation. And something that was mentioned, I don't know if it was Mina or Vincent, we are all work in progress. I love this expression because we are all a system in progress, meaning that we can all get better, we can be better, we can do things better. And we have to do this, but we need to be updated, streamlined. There's digital health. We know now that data need to be born digital, and they will continue being digital as the rich countries are doing. And they have been doing this for a lot. And of course, they have more money. And there's certain differences to note. But something that I liked the most is that the solution is here. It lies here in our countries. We learn a lot. We share experiences. We present, we hear about good practices, but in the end, ultimately, who will make the decision is the country. And this is why I am committing you to have a technical meeting, not a webinar like this one, those webinars that we've been having for quite a long time, but a larger meeting to discuss and see what we have, what we don't have, and what are the similarities and what are the differences. I loved the Quechua comments because of a simple reason. I was trained on violence at Harvard, and whenever we came back and started to train people in the country, there was a time of terrorism. Our psychiatrists and psychologists didn't know how to react. If it is difficult to express your emotions in Spanish, imagine having to speak another language and the other person speaking in Quechua. So it's actually, this intercultural approach is also something to rescue from all of this discussion. I would like to continue chatting and discussing and commenting on many of your points in the presentation, but time is of the essence and we need not abuse time. Once again, we are interested in having this technical meeting, and it should be on site with you. That will be very important, not only for Peru. I'm the executive secretary of the Andean Health Organization, and we work with 6 ministries: Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. And we are truly convinced that together we are stronger, and together we will reach farther. Well, thank you very much to everyone. See you soon. Goodbye. Bye-bye. Thank you.
Thank you very much. Bye-bye.
Muchas gracias.